All right, this is an example of Chirotouch's program by Dr. Hether using the Google Glass. We have our subjective, objective assessment and plan. This works a little bit better on the iPad, but I wanted to show you what it looked like on the PC form. So if I go under subjective and click on my exam findings, I can see that I can click what type of exam it is. Let's say it's an initial exam, and I'm going to review the intake with the patient. And I'm going to say again that this is an initial assessment on this individual, and that today's date is the 27th. This person has, let's say they have just one complaint instead of multiple complaints. And then we're going to go directly to the right and say, under complaints, we have how detailed do we want to be. Let's say we don't want to be that detailed. We just want to see, does this individual have neck pain today? The pain in the neck is rated about a 5, and that this is both tight and stiff. From there, we can go right over to the right under etiology and say that this etiology is for this pain is unknown, and that this date that we gave, it's an estimate. And then we simply say it's unknown, and then this is an estimate. From there, we're going to go to the far right and go under aggravating factors. We can ask him if standing causes aggravation. He's going to say no. We're going to say that walking doesn't cause any aggravation. He's going to say no. We're going to ask if sitting causes any aggravation. We're going to say sitting causes an aggravation in the neck pain, and this is noted after about 10 minutes. We're also then going to say that bending doesn't affect this. And then again, if there's any other additional information, we can type any other comments here and then end it with a period. We can ask the person what he's done that made this feel better. He says, I used Advil, I did heat, and I did a little bit of rest, and that takes care of some of the issues. And again, we can type anything that's not on the list there. From there, we're going to go over past medical history. We're going to ask the individual if they've had any broken bones. We're going to say no for this. We're going to see if they've had any surgeries. We're going to say no. And then if we're asked if they had any traumas, if yes, we would just click yes and then type what traumas they had there. And then again, we're going to go over if it's a female, whether they've had any children, and then again, any other information we want to add, we can add there. From there, we can ask the patient if they have a pacemaker or a defibrillator. Sometimes this question doesn't apply, but I like to ask it anyway. For general health, we can ask the individual that they have asthma and they have some sinus problems. And then from there, we go under, again, this is a non-gravid female. If it was a male, we would just click the non-applicable button. For family, we can go over different types of family history. For family history of heart disease. You can type what else you wanted in there. Personal habit, we can say that they do not drink, they do not smoke, they drink caffeine, about 1 cup a day or less. And then again, we can put down any recreational drugs. From there, employment, we can say the person is employed as, let's say the person right now is unemployed. And then that takes us over to their past, the primary care physician or their past chiropractor. We can add who their primary medical doctor is, whether they don't have one, or if they go to a facility for their medical treatment. And then there, we go right from there under objective findings. We can say that, again, for the exam, what is this person doing? Their gait, they have a normal gait. We can say that this individual appears healthy, cooperative. We can go under to the right to vitals. And from vitals, we can push the bullet format, which will say this person is, let's say they're at 5 foot, 2 inches, they weigh 100 pounds, and that their blood pressure is 120 over 80. And again, works just as well on the iPad. Respiratory pulse rate of 65, respiratory rate of 16. And then from there, we're going to say that their temperature was 98.6. We can go from there right into a review of systems. From the review of systems, we can ask them if they have any problem hearing or smelling. We can say normal vision, they have decrease in hearing. We can also mention that they have no problems with smells. From there, we can ask that if they had any digestive problems. Let's say they have a gluten intolerance. From there, we can go over that they have no problem with constipation or voiding. They have had surgery for a hiatal hernia. From there, we can ask that they had childhood asthma. From there, we can go under that they do not have any chest pains currently right now. They do not have any endocrine problems or thyroid problems. They have no skin irritations or rashes. They have a little bit of anxiety, and that we can mention that they are a female and they've had a recent mammogram, and then kind of go from there. The test was normal. From there, if it was a male, we could ask the male questions for the prostate, if it was appropriate age, and from there go directly to the right into visual range of motion. We're going to introduce the visual range of motion, saying that we're going to ask this. We can go into the visual range of motion and start asking the questions. They have mild restriction upon flexion. They have mild restriction upon extension. No problems with right or left lateral flexions, but they're going to have also some difficulty, moderate with rotation to the right and moderate with rotation to the left. From there, they say that they're going to have pain with both the flexion and extension. I'd end this with a period to make the sentence complete. And from there, we go right under reflexes. We can check the upper reflexes and say they are all normal as far as the upper reflexes. There would be the lower, and then this would be the upper and lower combined. From there, we go directly into muscle testing. We can test the muscles. And again, for the upper extremities, we can say that they were all fine too. And then from there, go right into our orthopedics. We're going to introduce the orthopedics and say that from there, for this complaint, that the person has, for the cervical spine, negative foramen compression, negative cervical distraction, and positive shoulder compression bilaterally, which is going to be mild on the right, and it's going to have moderate pain on the left. Again, we would end that with a period. We would say that this pain upon this procedure was in the neck, and from there we can go directly into palpation findings. We can say under palpation findings that this person has tenderness at C5 and C6, and that there is also muscle spasms noted in the cervical and the upper thoracic spine. We can say cervical and upper thoracic. From there, we go right under radiology. We can say that the person has not had any recent radiology. We could also say they have and what was done, or that we're going to refer them out. But for me, I'm going to take the x-rays myself. So here would be an example of what x-rays are taken. Why are we taking them? We can say that we want to structurally see the area. We want to look for visual alignment. We're going to say that the person has no motor defects, no structural defects, no worsening conditions. So that's enough for there. We're going to say that the x-ray is going to be taken on today's date, and then from there we are going to take a cervical spine. Just a 2 to 3 view should be adequate for this patient. From there we go directly under cervical x-rays after we take the x-rays, and then we can say that under the cervical spine that they have a normal curvature. They have a normal curvature. They have a slight anterior listing. Actually, let's go ahead and say it's a lateral listing. Lateral listing to the right from 5 to C1. And then from there, we're going to say that George's line is intact. We can say that the vertebral body heights are also intact. From there, we can ask a question regarding the ADI space. And we can say that there's a decrease in disc spacing between C5 and C6. From there, we can say that there is no degenerative joint disease. No degenerative joint disease noted. There is anterior exostosis noted between C5 and C6. Between C5 and C6, we end that with a period. There is no posterior exostoses. If there were, we would put down where they were located at, so this doesn't apply. We can say that there is no lateral exostosis to the right. We can say that there is no lateral exostosis to the left. Next is no exostosis, and then again, if it was, we'd put the information there. We would say that there were no fractures seen. We also have no problems with soft tissue, and then we can also put down whether there are any artifacts. Let's say there was an earring or so. From there, we could add any additional comments on the x-rays, and we could add our thoracic or our lumbar views if appropriate there. From there, we can go right under assessment. We can go under exams, what our diagnosis is. We're going to give this person an individual diagnosis of a subluxation at C5 and C6. Take off C4. And then from there, that we can say that these subluxations are related to the diagnoses of cervicalgia, and we'll also put down cervical segmental dysfunction. From there, we can go right over to the right under patient status, say the patient is acute, they're under initial care. We'll take that off after about 5 or 6 visits. From there, we can say the prognosis appears fair to good. Everything looks good for this individual. From there, we can type any other mitigating factors, functional outcome assessments. We can tell the computer that we're going to do a functional outcome assessment for this day of the cervical spine. So there was a single form done. And on this day, we're going to have the cervical test, and out of a score of 150 from the AMA pain index, we're going to say they scored about a 55 out of 150 after we've already had the patient done this. And our interpretation of this functional outcome assessment is that they have a regional functional deficit. We can change this to continues or no longer has as the condition continues, and we do an update exam on this individual. We can do functional limitations as far as this, limitations due to their pain. So we can say that on this date today that they have problems with cooking, driving, and exercising and lifting due to their neck pain, and these are going to be some of our goals to try to increase their functional limits of activity of daily living. From there in a plan, we're going to say, what is our plan? We're going to see this patient, and let's go ahead and create a treatment plan. I have ones that are already preset 2 times a week for 1 to 2 weeks, with therapy, without therapy, with just heat. So let's say I'm going to go ahead and say I want to see them 2 times a week for 1 to 2 weeks. We're going to do muscle stim and heat, and then we're going to reassess them after 10 to 12 visits. Our daily notes is going to say what we did. We're going to summarize what we had done today. We did an examination, we did an x-ray, we did a manipulation, and let's say we're going to do muscle stim and heat on this individual. We also had them fill out a copy of a functional outcome assessment. We're going to give them a copy of this. We're going to give them a copy of this because we're going to give them exercises and patient education, and then from there we had them fill out a single functional outcome assessment. From there, we go directly under the physical therapy and what therapy was done for this individual. We did muscle stim and heat for 15 minutes, and we did this lateral to T3 with heat applied to the neck and the upper back. And let's say we did this in a seated position. That way they could have filled out their functional outcome assessment on the iPad while we were developing the x-rays. From there, we're going to say that the manipulations were done to the cervical spine. Let's say we did C4 on the right and C5 on the left, doing a Gonstead method, and that we did no other adjustments. So C4 and 5 on the right and the left. And then from there, we're going to go on a return visit, and we're going to have this individual return once more at the end of this week. From there, we'll go directly into goals. Our goals are going to be, we want them to improve range of motion and strength. We want to also reduce their functional deficits from their functional outcome assessments, and we're also going to improve activities of daily living. We're going to say that the work is not the issue. And then again, our FOA goals for our cervical spine, where this person scored a 55, we want to see a 10% increase or improvement of this over the next course of the examination period of about 10 to 12 visits. Home exercises we can go directly into by clicking the right, introducing home exercises. And for the cervical spine, we're going to do a series of cervical exercises. I'll do this one right here. 3 to 4 days a week. We're going to do 10 repetitions each. Patient education, we could recommend that patient information. We can recommend that they quit smoking, how much exercise to do, information on signs of strokes. We can give them information regarding, let's say they're drinking too much caffeine. We can give them stuff about, warning signs about caffeine. We can talk about the different types about diets, DASH diets. If they have questions about diabetes, let's say they are concerned about gallstones, we can give them information about this by simply clicking any of these buttons regarding patient education. Back to plan, let's say I want them to use heat at home, and from heat we're going to tell them why we want them to use heat, and we're going to want them to use heat to their neck and their upper back, and no more than about 15 minutes. And again, we're going to reference where we're going to get this. So if we look at this as far as an exam point, we have our initial exam as far as the reports go, and we can say that we're going to assess this person. We're going to check their aggravating factors, their palliative factors, their general findings, family history, personal history, employment. We're going to go up to our objective findings, and we're going to read our objective findings. We know that we check their gait, their appearance. We check their vitals, their review of systems. We did range of motion for them, where their pain was, extremity, reflexes. We did muscle testing, orthopedic testing to the area. We're going to see that they have not had any x-rays, their palpation findings, what x-rays were done, why they were done, what the findings were of these x-rays. We're also going to go under assessment and just recap and say what their diagnosis is, what their status is, what their functional outcome assessment scores, where they were deficient in their functional limits of daily activities, and then what our plan is, how often we want to see this person. We said twice a week for 1 to 2 weeks. When we want to re-examine them, why we're doing physical therapy, what was done during the course of today's treatment, the physical therapy that was done today, the manipulations, which technique, which side, which vertebrae, when they wish to return, short-term goals. We can also put in some long-term goals if we wanted to by simply clicking between short-term and long-term, going to goals, and we want to improve long-term goals, we can say long-term goals are is to return to a functional outcome score of the cervical spine of close to 0. They were at 55, and that could be one of our goals as far as our long-term goals. We have the neck exercises here as far as what exercises we want them to do to the neck. As far as passive, we have active, we have different stretches, again, education, and then again, where they want to use heat, why they want to use heat. And if they have any questions on this, they're to contact our office. Stop any exercises if you have any pains. And then that pretty much is an example of how we do a functional outcome assessment and daily activities for an examination for an initial patient.